Chapter 21, Blood Vessels and Hemodynamics. We're going to start our lecture discussing blood vessel structure. Now, a blood vessel is going to have three consistent layers. Whether we're talking about arteries or veins, the layer names will be the same, albeit the anatomy of those layers may be a little bit different. So those three layers include the tunica interna. It's also known as the tunica intima. This is the innermost layer. It is adjacent to the lumen. It is made up of endothelial cells that is in intimate, hence tunica intima, contact with blood. The tunica media meaning middle, is the middlemost layer. It is made up of smooth muscle and elastic fibers. Now the outermost layer is called the tunica externa meaning external, and this layer is adjacent to our surrounding tissues. Now let's compare and contrast arteries versus vein. So we're going to start right here with our artery, and we'll outline it in black. So we'll start right here with the artery, and we'll identify the different layers. Now, the tunica interna, again also known as the tunica intima, is lined with a layer of simple squamous epithelium. And we can see that endothelial layer right there. From there, we have a connective tissue basement membrane with elastic fibers forming the internal elastic lamina. Now the middle layer, tunica media. I'm going to highlight this one because this is special for arteries. Now in arteries, this is the thickest, or tends to be the thickest layer. It's primarily smooth muscle, and the reason why it's smooth muscle is because it's going to provide support for these arteries by allowing it to change vessel diameter. This ultimately is going to regulate blood flow and blood pressure. Now the outermost layer is the tunica externa. Now this tunica externa, it's going to be made up of varying amounts of elastic and collagen fibers. Now the connective tissue in this layer is quite dense because it's adjacent to the tunica media, but also it changes the loose connective tissue near the periphery of the blood vessel. That brings us to our veins. Now the layer names are the same. We start with the tunica interna. We have that internal simple squamous epithelium followed by that basement membrane. What we lose here is the internal elastic lamina. Because veins are less rigid and less elastic, they do not take as much pressure as arteries. They do not need as much elastic connective tissue. The next layer, tunica media. Remember, it was the largest, so we can outline it here as the largest in arteries. Well, in veins, it is not. There isn't much muscle here. We are not changing the diameter much or as much as we get. We do get venoconstriction, but not as much. When we talk vasoconstriction, we're talking at the arterial level. So not as much constriction here. Now again, these are not pressure reservoirs. Arteries are pressure reservoirs. These are volume reservoirs. Veins deal with majority of the volume of blood. We're talking about 64% of your total blood volume is kept here in our veins. Now the largest layer, so our largest layer in veins is the tunica externa. Now again, this is the largest layer in veins, and we think the reason why it's thicker in veins is going to be to help prevent collapse of the blood vessel and also protect from damage, being that veins are more superficially located, meaning they're closer to the surface of the skin. Vessels of the cardiovascular system. So when we start our discussion, we're going to pick up with arteries and then outline all the different types of arteries and continue down into our arterioles, meta-arterioles, then our exchange blood vessels, or capillaries, and then pick up with our venules and ultimately veins. Arteries and arterioles. So we already outlined the anatomy of arteries with our tunica interna, our tunica media, and our tunica externa. Now let's look at the histology, because you will be responsible for identifying and differentiating arteries and veins. So we start in the center. We'll start right here with the lumen. This is where your blood is flowing. Remember that tunica interna or intima? We have that intimate relationship with blood. Well, here it is. And if we zoom on in, we can actually see this squiggly line here that we see is and are the elastic fibers in that elastic lamina, on that internal elastic lamina. Now, from there, we're going to go to our tunica media, and we can bracket it here, tunica media. Let me switch over back to red for you. Tunica media right here, and we're bracketing the space. Thickest layer in arteries, mostly smooth muscle is what we're seeing there. And that brings us to our external elastic membrane. So let's zoom on in, and look, it's the same conformation that we saw on the internal elastic membrane. Squiggly, 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 elastic connective tissue. From there, we hit our external layer, back to highlighter, our tunica externa. So that's this region. Let's turn it to gray for you. This region right there. So again, the review of our 3 different layers from a picture view, an anatomical view, histology, versus lab book or textbook. Now, the function of arteries is to carry blood away from the heart to the tissues of the body. Now, we already said that the walls of arteries are elastic. They need to be. They need to be able to recoil elastically from that pressure that they're absorbing. So when those ventricles beat, they're pumping blood into the arteries at an extremely high pressure. If you go back to our previous lecture, we said that that was roughly about 120 millimeters of mercury, and that's assuming if you have a normal blood pressure, not hypertensive. Now, those arteries have to be able to resist that pressure and recoil elastically. Now, because of the smooth muscle in the tunica media, arteries are able to regulate their diameter, ultimately regulating blood flow and either increasing or decreasing blood pressure by increasing or decreasing resistance. So let's classify our arteries. We'll start with the largest of our arteries, our conducting arteries. They're also known as elastic arteries. And the reason why they're known as elastic arteries is because they have so much more elastic fibers and elastic connective tissue than some of our other arteries. They also have less smooth muscle. They are the largest diameter. So these would be arteries like our aorta. So our aorta is a great example. About the size of a small garden hose. So if you pick up your garden hose and say, oh, this is about the size of my aorta. It functions as, here's our major word that we introduced before, pressure reservoir. So it is a major pressure reservoir, okay? So remember that. Our next classification or type of arteries are our muscular arteries. So I like how their name kind of implies what they do, right? Elastic arteries need to be elastic to resist that pressure and recoil elastically. Our muscular arteries are just that. They have more smooth muscle, they're more muscular, they have fewer elastic fibers. These are also known as distributing arteries. They're medium diameter, and their job is just to distribute blood to various parts of the body. So I use an analogy to kind of explain elastic arteries, muscular arteries, our arterioles, meta-arterioles to the capillary beds. And I like to use our highways and byways to kind of explain how this works. So if you consider our elastic arteries, well, now, before we even get into the analogy, think about a highway, right? It has 2 lanes. It has, or 2 sides. The traffic that you're moving in and then traffic coming against you. If you think about this as one side's arterial end and the other side is venous end, it kind of makes sense. Now, let's pick a place. Let's pick a university. Say, pick any school that you go to, right? And this is going to be essentially like the heart, okay? Now, you're going to leave that school and you're going to jump on the highway. Now, once on that highway, think about the lanes. There's 4 lanes, right? So we can put a ton of traffic on that highway. Now, you get off an exit like you're going to your house. That exit brings you onto another major road, a lot lesser lanes, maybe only 2 lanes, right? So we're going smaller in size, less traffic. We're going from major conducting arteries, conducting roads, to distributing arteries or distributing streets. Now that main street is going to take you to a side street, right? These are like your arterioles, which is going to lead you to maybe another street, a meta-arteriole, that's going to lead you to the capillaries. Now, this would be essentially the road that you live on. Your house will be your capillary. What do you do at your house? You eat, you rest, you recoup, you build up your energy again, and that's kind of what's going on at the capillary level. Then you jump right back on to our metavenules, to our venules, to our veins. So we go back on the side road to the main road to the highway to get back to school. So again, we're using the analogy of our highways, our byways, our roads, and our side roads, and our home streets to kind of bring this together and make sense out of it. Now we talk about arteries as pressure reservoirs, and those are the major elastic arteries. So the aorta and elastic arteries, blood's flowing towards the capillaries, the left ventricle's contracting, and that pressure is being exerted on the artery. Now, that artery has to be able to recoil elastically and resist that pressure. So elastic aorta and arteries recoil during ventricular relaxation. During ventricular contraction, the artery is going to stretch and then come back to its original size. So we call that elastic recoil. The next structure we're going to talk about are an anastomoses. Now again, I use an analogy to kind of make sense out of this. I don't know if any of you have seen Peppa Pig. In Peppa Pig, they always talk about driving on the roundabouts, right? These roundabouts, these turnarounds, what they are a circle off an exit that has multiple exits. Now, those multiple exits can go different places, or they can even go to the same place, but the purpose of these, they're actually modeled after the anastomoses, the roundabouts in our body. Anastomoses are unions of the branches of two or more arteries supplying the same region. The good example that we have in our brain, the circle of Willis, right? So we have this circle that has multiple entrances and exits, and what this does is it allows for collateral blood flow. So what does that mean? It's providing an alternate route for blood flow in the case that something happens. So say this artery leads to here. This artery leads to here, but can also lead to there. So what happens is if this artery, let's say, gets damaged and gets blocked, we can recirculate blood flow through this exit to sustain supply to that area. So they're providing alternate routes for blood flow. So again, if the artery is blocked, blood cannot get to that particular region of the body and necrosis can occur. So that's why it's important that we have these in our body. I mean, they're all over the place, in our brain, in our wrists, behind our knees, in our organs, right? Everywhere that it's important to have this collateral blood flow. Now, not all arteries lead to anastomoses. Some lead to things called end arteries, like in your fingers, your fingertips. These arteries simply end at a capillary bed and return back to the venule side and then the venous return side. Now, why is this important? Because think about diseases, right? Pathology like diabetes. These end arteries are the ones that suffer first because we do not allow for collateral blood flow, which is why if you look at your grandparents or great-grandparents who suffer from diabetes, you see a lot of times they have fingers, toes, limbs amputated because of these end arteries. That brings us to capillaries. Now, anatomically, capillaries are a lot different than arteries and veins because of their makeup, their structure, their formation, and essentially their function. Now, capillaries have a endothelial simple squamous cell line, and they have a basement membrane, and that's pretty much it. They're very, very small, right? So if you think about the size of a capillary, we're talking a few microns wide, enough to fit a single red blood cell. So we find one red blood cell stacking behind the other. And remember, red blood cells have this unique ability to form stacks, also called rouleaus. And the reason why those red blood cells are flexible is because they can bend through these really, really tiny lumens of the capillaries, okay? Capillaries are these microscopic vessels that we just talked about. They usually connect arterioles to venules. Now, we already said that capillary walls are composed of a single layer of cells and a basement membrane. Why are their walls so thin? We're allowing for the exchange of nutrients and waste between blood and the tissue cells. And again, as we continue through AP2, we're going to see that every system we're talking about, whether it's the cardiovascular, whether it's the respiratory, the digestive, the urinary system, reproduction, we're going to see that a lot of these physiological functions, a lot of these exchanges or movement is going to be based on one thing. And that one thing is going to be pressure. So pressure is going to be key here, and setting up pressure differentials is going to be key to be moving nutrients and wastes in and out of these capillary networks. Blood flow through capillaries. Now capillaries branch to form an extensive capillary network throughout the tissues and are found near almost every cell in the body. So let's take a look at this. We see that sphincters relax. So what are sphincters? These ring-like muscles. What do they allow? They guard entrances and exits. So we have an arteriole, and look at all the smooth muscle around that arteriole, being able to control the diameter, coming from the heart and leading to this capillary. Now as we get to the capillary, smooth muscle diminishes to nothing, right? Remember, there's no smooth muscle in the walls of these capillaries. But something does occur. We have to be able to regulate pressure. If blood volume's low, we have to artificially increase pressure so that we are still delivering nutrients and oxygen to our tissues. So what do we have? We have precapillary sphincters. Now with the precapillary sphincters relaxed, blood is flowing at an optimal rate through the capillary bed, and we see the changeover from red to blue, signifying nutrient-rich to nutrient-poor, oxygen-rich to oxygen-poor, back into our venule or muscular venule that's going to lead back to our veins. Now at the flip side, let's contract those sphincters. What's happening? From the heart, blood's coming in. We're closing off part of the capillary, artificially increasing pressure, forcing it through only one thoroughfare, which will increase the loading and unloading of nutrients and gases here, and then ultimately out of that muscular venule. That brings us to three different types of capillaries. We're going to start with a continuous capillary. Now, they are continuous in the sense, as their name implies, that the endothelial cells that we see here, right? So we see a nucleus of an endothelial cell here. These endothelial cells provide an uninterrupted lining in that they only allow smaller molecules like water and ions, some hormones, sugar like glucose to pass through it. So where do we find these? These capillaries have no perforations. They only allow small molecules to pass. We find this in places like muscles, skin, fat, and nervous tissue. So I'll introduce the second type, and then I'll tell you my analogy. The second type of capillary we find are fenestrated capillaries. Look at the picture. We find these pores. That makes these capillaries leakier than continuous capillaries. They have these small pores in addition to gaps. Look at these gaps between the cells. That's going to allow for exchange of larger molecules, okay? And then this is going to require the exchange between blood and tissue. So we're going to find places like the small intestines, endocrine glands, and the kidneys are going to utilize these type of capillaries to allow for, and really size restrictive, certain things like sugar, small proteins, small molecules to leak into the blood. Now, specifically, if you go back to AP1, we've talked about the histology of the kidneys. In simple squamous epithelium, we use that analogy of a ball in a ball, right? We talked about Bowman's capsule, the outer layer of this parietal structure that's going to take blood in, and then this fenestrated capillary, right? This glomerulus, the ball within the ball, glomeruli means ball, right? That glomerulus that's going to take that blood and filter it. Okay. And what are we filtering? We're blocking, that's why it's size restrictive, large structures like albumins, large proteins, right? We're blocking these red blood cells, white blood cells, all the large components of blood, and allowing small stuff to leak. That's why we're a little leakier, leak on through. The third type of capillary is a sinusoidal capillary. These are typically found in the liver, spleen, lymph nodes, bone marrow, and some endocrine glands. Now, look at the holes, look at the gaps, huge holes. This is important so that we can utilize, like for example, the spleen can use these capillaries as a filtration mechanism, filtering the blood, removing antigens, removing defective red blood cells. These large structures can pass through those holes, right? And also removing microorganisms. If we go to our bone marrow, how are we introducing these red blood cells, white blood cells into circulation? We're letting them come through these sinusoidal capillaries. So here's my analogy. I think of Dunkin' Donuts or Starbucks. I think Dunkin' Donuts is the best bet because they have a bunch of straws just sitting in a container. So let's take one of those straws, right? And we'll leave it intact. We're going to consider this a continuous capillary. So get yourself a nice iced coffee, and Dunkin' Donuts puts all the sugar in the bottom. It never really dissolves all the way through in that iced coffee. So you have the water, you have the sugar molecule, right? So the sugar represents all the large things in blood, and the water represents your plasma, right? Your blood, or the coffee represents the plasma in your blood. Now, stick that straw in there. Your mouth is the muscle, the fat, the nervous tissue. You take a big sip, you're getting a ton of coffee, a ton of that sugar right into your mouth. That's a continuous capillary. Now let's take that same straw. Now I'm going to punch 100 holes into it with a little needle, right? Nothing too crazy. Now I'm going to tell you to take a sip again, okay? Now you're going to take a sip, and you're going to get a lot of sugar into your mouth, but we're going to see some of that coffee is going to squirt and leak out of those holes. Now let's take this sinusoidal capillary. Now instead of using a needle, I use a knife or a fork, and I punch massive holes into that straw. And I tell you, take as big of a suck into that straw as you can. What's going to come to your mouth? Very little water, and even those big molecules of sugar are going to push out of those holes. So not effective to get a whole bunch of nutrients and blood and stuff to one area, but more again filtering. That's our goal of these different capillaries, filtering. Veins and venules. So before we get into the specifics of veins, my old adage that a picture speaks 1,000 words, we're going to look here to help us understand how veins work. Now, remember, we have our three layers, our tunica interna, tunica media, and tunica externa. Again, that tunica externa being the largest layer, so we'll write largest layer here, in veins. Now, remember we said that veins were volume reservoirs, right? They contain the majority of our blood. 62 to 64% of the volume of our blood, our entire body's blood, lies resting in our veins. So we know that arteries rely on pressure because they're pressure reservoirs, right? So how, if there's very little residual pressure after the capillary bed, how does blood get back to the heart through our veins? Now, we rely on three mechanisms. So we'll write here three mechanisms. And those three mechanisms, one of them is right here in the picture, and here it is. So we rely on valves. So every time you take a step, right? So we'll introduce number 2, which is muscular pump. So veins run between big muscles like your gastrocnemius and your soleus, and every time you walk, every time you contract a muscle, the contraction of that muscle helps to push blood back up to the heart. Now, if you stop moving, it stands to reason, if you're relying on that movement to move blood, if you stop moving, then blood would either, because of gravity, go back to your feet, or kind of slowly trickle its way downward, right, back to your fingers or whatever. So the body had to come up with a way to prevent this, and that was with our number 1 valve. So every time you take a step, the valve opens, blood moves, and then you stop moving, the valve slams shut and prevents backflow. The third way we get some residual draw of blood back to the heart with our respiratory pumps. Okay, so every time we breathe, the respiratory pumps. Every time we breathe, that pressure of blood moving into the lungs and then subsequently out is going to help draw that blood back up to the heart. Venules. Now, our venules are small vessels that are formed by unions of several capillaries. So we go from exchange at the capillary bed level to our venules. Our venules then will drain blood from capillaries into veins. Veins are formed from the union of several venules. So again, we're going from the smallest component, the capillaries, to our venules, all the way to our veins. Compared to arteries, remember veins have that thinner tunica interna and media and the thickest tunica externa. They have less elastic tissue and less smooth muscle than arteries, so they can contribute less to vasoconstriction. We do get a little venoconstriction, and we'll write that word in here, venoconstriction, with veins, because we do have a little layer of smooth muscle, but nothing as compared to arteries. And remember, we have very little pressure here, so we do not require as much elastic tissue, we do not recoil as much as arteries do. And also lastly, as we said on our previous slide, veins have valves, again preventing backflow. So again, picture a muscle pushing in on this vein, squirting blood up, and then the valve opening and subsequently closing. So table 21.1 goes through all the different blood vessels, their size, their tunicas, interna, media, externa, and their functions. So everything we've covered in the past few slides, all tied up neat into a nice little package. Things you do not need to know. We know the size, you do not need to know the microns, right? 15 to 300 microns in diameter. You do not need to know that. So you can skip some of that extraneous information. Other than that, you should know which has a well-defined tunica interna, thickest media, or thickest externa. Why? Based on their function. So you can break apart this table based on what we talked about so far. So a nice little pie chart to explain where all the blood in our body, remember we have anywhere from 5 to 7 liters, depending on if you're male or female, circulating at any point through our body. Now at rest, the largest portion of blood, as we said before, is in our systemic veins and venules. These are our blood reservoirs, our volume reservoirs, so about 64%. Our heart has about 7%. Our systemic and pulmonary vessels 9, systemic capillaries 7, and our systemic arteries and arterioles 13. So again, in our arteries and arterioles, we have a relatively small percentage, 13% of the amount of blood in our body. To our lungs, 9%, heart and systemic capillaries about the same at 7%. But again, look at that big pie chart. This pie chart tells a lot. It shows you how big the lumen of veins really are and how much blood really rests in them. And again, this can be problematic, right? The reason why is because there's so much blood in these veins. If you're sedentary for a long period of time, this blood tends to, since it's stagnant and it's kind of just sitting there and sloshing around between those valves, it kind of forms clots. And this is where it could be dangerous, because once you get up and start moving again, those clots tend to move. And as they move, they can move to your lungs, to your brain, in your lungs, causing a pulmonary embolism. So this could definitely kill you. So this is a real problem, which is why it's important to be moving, which is also why if you're going in for surgeries that are 4, 5, 6, 7 hours, and even post-surgery, if you're really incapacitated, like say with major open heart surgery, they put leg compressions on you. And those leg compressions will contract and expand and contract and expand down on those legs all day long, simulating that moving to keep blood moving to kind of reduce your risk and prevent clots from forming. So we're going to come back and visit our capillaries and look at capillary exchange. Now, how do substances, oxygen, nutrients, we've talked about this loading and unloading of oxygen, this loading and unloading of carbon dioxide, loading and unloading of nutrients and wastes, but we never really discussed how that occurs. So we have 3 processes here. One is going to be diffusion. The second will be transcytosis. The third, bulk flow. Now we're going to start with diffusion. Things like oxygen, carbon dioxide, glucose, amino acids, and some smaller hormones can cross the capillary wall through simple diffusion, which again is based on large concentration gradients. The second mechanism is transcytosis. So large lipid-insoluble molecules like insulin cross the capillary wall in vesicles via this process of transcytosis. So again, this is our key. We're talking about large molecules. So the molecule is endocytized by the endothelial cell in a lipid vesicle. Now that vesicle is going to move through the cell and then get exositized to the other side. A nice efficient way of, again, moving large versus smaller when we deal with diffusion, large molecules through the cell, through the capillary. Now the last is bulk flow. Now bulk flow is a passive process in which large numbers of ions, molecules, or particles in a fluid move together in the same direction. Bulk flow occurs from an area of high pressure to an area of lower pressure, and it continues as long as that pressure differential exists. Now bulk flow is more important for regulation of relative volumes of blood and interstitial fluid. So again, just to reiterate that the movement of materials across the wall is dependent on pressure and is bidirectional. So that's really important. It could go either way. But again, it could go either way depending on a couple principles, depending on net filtration pressure, which is derived from the four Starling forces that really modulate this capillary dynamics. Now, those four Starling modules, or those four Starling laws, are oncotic or colloidal osmotic pressure, and we'll talk about that in a little bit. It's a form of osmotic pressure exerted by proteins in the blood plasma or interstitial fluid. We're going to talk about hydrostatic pressure, which is the force generated by the pressure of fluid within or outside of the capillary on the capillary wall. So filtration and reabsorption is what we're kind of talking about. And here's our four Starling forces that are really driving the dynamics of this capillary filtration. So filtration, again, here's our key word, is a, remember we said we always go back to this, a pressure-driven movement of fluid and solutes from blood capillaries into the interstitial fluid. So we're dealing with a couple forces. Number one, blood hydrostatic pressure, which is the pressure that the fluid in blood exerts onto the capillary bed. Now next is the interstitial fluid osmotic pressure. So we're talking about the pressure outside of the capillary in the interstitium that is drawing or promoting outward filtration. For reabsorption, it's pressure driven again, so we see our pressure driven word again, and that's our take-home message here. Pressure-driven movement of fluid and solutes from the interstitial fluid into the blood capillaries. So we deal with interstitial fluid hydrostatic pressure. So the pressure of the fluid in the interstitium surrounding the capillary, what that pressure is exerting onto that capillary bed. And then again, the blood colloidal or octonic osmotic pressure, so BCOP. This is all those proteins, all the red blood cells, all the formed elements in blood is exerting a pressure onto that capillary as well. Now, the take-home message is we're going to be adding and subtracting these forces. So when we look at our next slide and we look at pressure differentials, right? When we talk about net movement into the capillary or net movement out of the capillary, think about how things move. From higher concentration to lower concentration, from higher pressure to lower pressure. So these are the forces, these are the dynamics I want you to think about as we look at our next slide. So let's take a look at our dynamics of capillary exchange. So we're going to start taking those four forces that we talked about, adding them and subtracting them, and seeing how net filtration pressure either promotes filtration or promotes reabsorption. So let's understand first what's going on. On the arterial end, the ultimate goal is to have net filtration pressure be a positive number. So again, we're promoting net filtration. Remember, we're moving substances from a higher pressure to a lower pressure. So this should make sense, right? So what's the goal of the capillary at the arterial end? We want to unload oxygen, unload nutrients. So we want net filtration pressure inside the capillary to be higher, which is going to force these constituents, the oxygen, the nutrients, out of the capillary into the interstitium. So now on the venous end, we want the flip side, right? We want to go from a high pressure to a low pressure. So we'd expect the pressure inside the capillary to be a negative number. Okay, so again, if the interstitium is higher, it's going to force and drive constituents into the capillary bed. Now, what are we doing at that venous end, right? We're loading into the capillary, loading into the blood carbon dioxide and waste. So as we're adding these numbers together, keep that in mind. If the pressure is higher inside, it's going to promote outward filtration. If the pressure is higher outside, it's going to promote inward reabsorption. So let's take a look at some of these numbers. So we look at blood hydrostatic pressure, and we'll circle it right here. It is about 35 millimeters of mercury. So blood's coming in through the arterial and into the capillary. The pressure of the water component of blood is about 35 millimeters of mercury. Then we have this blood colloidal osmotic pressure. Remember the big things in blood, the proteins, the albumins, the fibrinogens, the red blood cells, the white blood cells are also going to exert a pressure of about 26 millimeters of mercury. Then we deal with the interstitial fluid osmotic pressure. So what's the fluid and the parts outside in the interstitium that is trying to draw out what's in the capillary, and it's a small number of about 1 millimeter of mercury. And then the last number we're going to deal with is we're going to see this interstitial fluid hydrostatic pressure. Okay, and that interstitial fluid hydrostatic pressure on this end is about 0 millimeters of mercury. Then we go to our venous end, and we talk about blood hydrostatic pressure, and it's dropped significantly, right? Because again, what did we do? In the arterial end, we're promoting outward movement. So we're down to 16 millimeters of mercury. Our blood colloidal osmotic pressure, these are relatively big substances. They're not moving through the capillary wall, so that remains constant at about 26 millimeters of mercury. So let's see what's happening. On the net filtration at the arterial end, we're processing, and I'll highlight this for you, about 20 liters a day. On the venous end, we're processing or reabsorbing about 17 liters a day. Again, remember when we say processing, and what we're talking about is the loading and unloading of oxygen, carbon dioxide, and nutrients and wastes. Now, let's look at the formula for net filtration pressure. Now, NFP, so there's NFP, is we take blood hydrostatic pressure and interstitial fluid osmotic pressure, and we subtract that from blood colloidal osmotic pressure and interstitial fluid hydrostatic pressure based on what end we're at. So let's start at the arterial end. BHP is 35 millimeters of mercury, and there it is. So let's highlight each one as we're talking about. Maybe we'll do it in gray. 35 millimeters of mercury. We add that to interstitial fluid osmotic pressure is +1. Then we subtract BCOP, which is 26 on the arterial end, and we add that to interstitial fluid hydrostatic pressure, which is 0. So we do our quick math. 35 plus 1 is 36. Subtract 26 is let's highlight this, a net filtration pressure of 10. Now look at that. Plus 10, plus 10. That's good. That means inside this arterial end, net filtration pressure is a positive number, meaning we're going to promote outward filtration, so from high to low. Now let's look at the venous end. Let's take the similar situation and let's start adding things together. We know that blood hydrostatic pressure drops on the venous end to 16. We still add our interstitial fluid osmotic pressure +1. That brings to 17. And we subtract our blood colloidal, that remember remains the same, plus interstitial fluid hydrostatic pressure is 0. So 17 minus 26 is, here we go, drum roll, -9. -9. That's the key right there. This -9. So inside is more negative. What does that mean? We go from high to low. Net filtration pressure is that negative number. We're promoting net reabsorption. So all this stuff is moving back in, net reabsorption. So the carbon dioxide, the waste from the interstitium is moving back in. And so that takes care of our dynamics for this capillary exchange. But one last thing I want to point out to you. Look what's kind of hanging out right above, and I'll circle it for you, right above this capillary bed. And that's going to be our lymphatic capillary. So when we talk about lymphatics later on in the semester, remember this picture. Remember that lymph ducts and lymphatic capillaries are going to be intertwined into our circulatory capillaries because they follow the same rules. They're going to have valves. They're going to rely on muscular pumps. They don't have much pressure. Remember, these lymphatics are our sewer system of our body, picking up the waste, picking up anything that has to be remediated or removed from the body, and especially removing water, plasma. So if you talk about conditions like edema, where if you sit in a plane for too long and your feet swell, that's because your lack of movement is not allowing these lymphatic capillaries to pick up that fluid and move it back to the circulatory system. So you build up fluid in those tissues. But when your feet swell, when you have edema, the solution is to walk, right? Move. Movement promotes movement of fluid into the lymphatic capillary and then back to the heart to introduce, or back to our venous flow to introduce it back to the heart to get redistributed through the body. Starling's law of the capillary. So kind of summating everything we've talked about, remember that Starling's law of these capillaries basically states that the movement of fluid between the capillaries and the interstitial fluid is due to the net effect of our four pressures: BHP, IFOP, blood hydrostatic pressure, interstitial fluid osmotic pressure; BCOP, blood colloidal osmotic pressure, and IFHP, interstitial fluid hydrostatic pressure. Now again, the volume of fluid and solutes reabsorbed is almost as large as that has been filtered. And remember, we're talking about 20 liters on the arterial end versus 17 liters. So it's almost equivalent when we talk about net filtration pressure on the arterial versus venous end of our capillary bed. Factors that affect blood flow. So blood flow is the volume of blood that flows through any tissue in a given time period, and we measure this in a volume of milliliters per minute. So recall that total blood flow is cardiac output. This is the volume of blood that circulates through systemic or even pulmonary circuits, blood vessels, each minute. So we have our formula. Remember, cardiac output is heart rate times stroke volume. We came up and discussed that and ran through some scenarios in our previous lecture. Now, we can also calculate cardiac output by looking at mean arterial pressure and dividing it by resistance. So resistance is a new word for us. And remember when we talked about afterload, we talked about the clamp on that artery applying a resistance. Now that resistance could be in increasing the length of blood vessels, can be increasing the amount of atherosclerotic plaque in those arteries, which is decreasing the size of the lumen. How do these happen, right? Poor diet choices, high cholesterol, of our bad cholesterol. As far as increasing blood vessel length, obesity is a major factor. For every pound of fat, your body makes about 2 miles more blood vessels. So that's crazy to think about. So if you put on 10 pounds extra of weight, right, 10-pound weight gain of fat, not muscle but fat, you're adding essentially 20 more miles of blood vessels. Think about that. You're adding more length, less blood flow, increased pressure to reach all that increased length. So this is why we get higher blood pressure. Now let's talk about blood pressure. Contraction of the ventricles generate blood pressure. Blood pressure is determined by cardiac output, blood volume, and again, vascular resistance. The higher the blood pressure, the greater the flow. We talked about words like systolic blood pressure and diastolic blood pressure. We said that our blood pressure to the aorta, and then once we get to our distributing arteries like our brachial artery in our arm, this is what we measure. A good blood pressure should be around a systolic value of 120 over a diastolic value of 80. So this means, well, what does systolic mean? When the ventricles are contracting, right? And then the diastolic value is when they are relaxing. So this is our value. So look at our pressure. So we see at about 110 systolic pressure in the aorta. So again, this is a lot lower than or an average value, right? 110 to 120 is where we'd want to be. And then right here, 70 to 80 for diastolic pressure. And then once we hit those arterioles, this is our key take-home message, that pressure drops, right? And this is important because in the capillaries, look at where we're at. We're at about 25, 30, all the way to about 18. Remember, we can't have a lot of pressure driving through these capillaries. It can rupture them. It can force more constituents out than what we need, than what we want. Okay, so we have to lower that pressure. And then once we get into the veins and the venules and the veins and even the vena cava, that pressure is really, really low. We're close to zero here. And that goes to show you the dynamics, those hurdles that veins had to overcome to get blood back to the heart because this pressure is so much lower. So things like those valves, those respiratory pumps, and those muscular pumps, the body had to utilize other types of systems to get blood back to the heart. Vascular resistance. So we've been talking a little bit about resistance and some factors that affect resistance, but resistance is the opposition to blood flow due to friction between blood and the walls of blood vessels. The higher the R, so the higher the resistance, the smaller the blood flow. Now, resistance depends on a few things. One, total blood vessel length. We talked about increasing blood vessel length with things like obesity. Blood viscosity, so the thicker the blood, the harder it is to flow, so the higher the resistance. So conditions like polycythemia, when we talked about too many red blood cells in blood causes this thick, viscous blood to flow. This can also affect R. Size of the blood vessel lumen. So obviously with fight or flight, blood vessels tend to constrict, increasing blood pressure. So this can increase resistance. Clinical conditions like high cholesterol or increased atherosclerotic plaque buildup in blood vessels lessens the size of the lumens, the openings to those blood vessels, increasing resistance. Venous return, so we've discussed this in depth. We wrote it on a previous slide. So the volume of blood flowing back to the heart through the systemic veins occurs due to pressure generated by the contractions of the heart's left ventricle and all these three mechanisms. So venous return is assisted by 1, valves, 2, respiratory pumps, 3, skeletal muscle pumps. We did review this on our previous slides. A nice little picture of our skeletal muscle pump. You can see that the two muscles on the anterior and posterior aspect contracting down, the valves located above proximal and distal, so the muscle contracts, pushes blood up, and we see it here. Blood's going this way and going this way. Valves are open. You stop. The valves close. Blood goes back down, but it doesn't have very far to go because the valves are closed. Let's use a chart to discuss velocity of blood flow, right? And the cross-sectional area of the blood vessel. So blood flow is the volume of blood that flows through a tissue in a given period of time. Now, the interesting note is that blood flow is inversely related to the cross-sectional area of the blood vessel, meaning as we start at the aorta has a relatively low cross-sectional area compared to as we start moving into the capillary bed. So those massive capillary beds give you this extraordinarily large cross-sectional area. And then as we move into our veins, into our vena cava, that cross-sectional area again decreases. So again, we see that the velocity of blood is inversely, so it's the opposite, related to the cross-sectional area. So what's going on here? So as you proceed to the periphery, the total vascular bed is going to enlarge. So as we move to the capillary bed, it's enlarging, and blood velocity falls. So the next question is, well, how come if the vena cava and the arteries are roughly the same, the velocity is about half, right? Well, let's go back to veins. Remember, our veins have those large lumens. It has a larger cross-sectional anatomy, so this is one reason why we see about half the amount of velocity moving through the veins as we do moving through the aorta, so the vena cava versus the aorta. Factors that affect blood pressure. So let's put everything we've talked about into a nice, neat little flow chart to explain how we increase mean arterial pressure. So number one, we talk about increased blood volume, those skeletal muscle pumps working, respiratory pumps working, and even venoconstriction is going to increase venous return. This increases stroke volume, which ultimately increases cardiac output, increasing mean arterial pressure. Decreased rest and digest impulses. Now, increased fight or flight, increased hormones from the adrenal medulla, adrenaline. This increases heart rate, increases stroke volume, ultimately increasing cardiac output, and then again, increasing mean arterial blood pressure. Now, let's look at some of our conditions. Obesity, right? Here's one. Obesity. Polycythemia. 2. Increased blood viscosity with polycythemia. Increased total blood vessel length with obesity. Increased resistance, systemic vascular resistance, SVR, which again increases mean arterial pressure. Decreased blood vessel radius, vasoconstriction, or even with pathology with disease like atherosclerotic plaque, increased SVR, increased mean arterial pressure. Who controls blood pressure and blood flow? We go back to our good old friend, the medulla oblongata. So the medulla oblongata contains our cardiovascular center, which is a group of neurons that regulate heart rate, contractility, and blood vessel diameter. So, input to the cardiovascular center, nerve impulses from the higher brain centers, the cerebral cortex, the limbic system, and the hypothalamus. From those proprioceptors, baroreceptors, and chemoreceptors, we're monitoring joint movement, blood pressure, and blood acidity. Now, the output to effectors, we're talking to the vagus nerve, parasympathetic, which is going to decrease heart rate. So increased frequency of nerve impulse is going to decrease heart rate. Cardiac acceleratory center, sympathetic, increase heart rate and contractility. Then we have our vasomotor nerves, our sympathetic center for blood vessels, which is going to deal with vasoconstriction. Baroreceptors are important pressure-sensitive sensory neurons that monitor stretching of the walls of blood vessels and the atria. We find them in a couple places, some key places that we need to really regulate pressure. So we talk about the carotid bodies, these baroreceptors located in these carotid sinuses. We find them in the aorta. So again, these stretch receptors detecting pressure in the aorta. On the atria, on the SA node, and the AV node, and in the ventricles, the myocardium of the ventricles, all places that are governing the force of contraction as well as monitoring the pressure to key components, like the aorta, like to the brain, okay? Let's look at a negative feedback loop for the regulation of blood pressure, kind of put it to cycle. So we start with the stimulus that's going to disrupt homeostasis by decreasing blood pressure. The baroreceptors in the carotid sinuses and the arch of the aorta detect this. They stretch less, which decreases the rate of nerve impulses. Then we have our control centers. Our cardiovascular center in the medulla oblongata and the adrenal medulla are going to increase output. So we get increased sympathetic by suppressing and decreasing parasympathetic stimulation. Increased secretion of adrenaline from the adrenal medulla, which affects the heart and the blood vessels. As an effect, we get an increased stroke volume and heart rate, which is going to lead to an increase in cardiac output. We're going to constrict the blood vessels, increasing SVR, systemic vascular resistance. Ultimately, we get our desired result, which is an increase in blood pressure. Now, this system will continue to stay in place until we return back to homeostasis, which everything will then negatively inhibit and shut down. Table 21.2 goes through hormonal regulation of blood pressure. So there's a couple take-home messages here. When we talk about the factor influencing blood pressure and the hormone and the effect on blood, look at our overwhelming increase in blood pressure. So cardiac output, increased heart rate and contractility, adrenaline, norepinephrine, and epinephrine. Result, increased blood pressure. Vasoconstriction, angiotensin 2, antidiuretic hormone, norepinephrine and epinephrine increase blood pressure. When we talk about blood volume increases with aldosterone or ADH, antidiuretic hormone, increase of blood pressure. Now we can look at a few instances that decrease, so vasodilation, so atrial natriuretic peptide, epinephrine, and nitric oxide, again that big vasodilator, which decreases blood pressure. So there's always a question here. Why do we see epinephrine and during vasoconstriction and vasodilating acting as both an increaser and a decreaser? So this basically has to do with the receptor. So it's acting on beta 2 receptors and arterioles of cardiac and skeletal muscle. So norepinephrine has a much smaller vasodilating effect here. So that's that little caveat there. And then ultimately, lastly, for blood volume, we decrease blood volume. Atrial natriuretic peptide is the hormone that does that, AMP, and again, decreasing. So a couple things that decreasing, again, AMP is that driving force here to decrease blood pressure. Autoregulation of blood pressure. So autoregulation is basically the ability of a tissue to automatically adjust its own blood flow to match its metabolic demand for delivery of oxygen and nutrients and removal of wastes. Now, there are physical and chemical stimuli that can lead to autoregulation, but for the most part, our body during fight or flight, rest and digest has the ability to adjust its blood pressure as an on-demand, as-needed system.